So this live transmission is going to be from Greenville Memorial Hospital in Greenville, North Carolina. And it'll be performed by Dr. Bruce Gray, and he needs no introduction, a very prominent interventionalist. And we have an esteemed panelist, including Dr. Nazzal, Dr. Henao, Dr. Soukas, Tony Das, Dr. Rosenfield, Dr. Mena, and Dr. Prakash Krishnan, and Dr. Mehdi Shishabor. So,
when you get a chance, can you go back to the control? And we're going to run through the pictures. I'll tell you when. Tee up the very... We're live. Hey, welcome from Greenville. This is Dr.
Banerjee.
Gray, and got Dr. Mike Devane, interventional radiologist. Lee's our scrub. Wendy's working the pictures, and thanks for having us here.
Thank you very much,
right
and go right into the case.
Yeah. This is, she's now 21, and she presented with phlegmasia cerebral edolins of the left leg, postpartum, and at that time, she was having pain, the swelling, and she underwent catheter-directed thrombolysis from a access in the short saphenous vein behind that left leg. And then the infrainguinal veins cleared up quite nicely with that initial procedure. She didn't have any history of a PE, and with her very first pregnancy, she had no history of previous DVT. Her venous clinical score at the time of presentation was about 6, and now she's a CEAP-3, now 2 months out of that thrombolysis adventure. She's been taking Eliquis, but her chief complaint is that of persistent leg swelling and redness. Next slide, please. So here you'll see the initial venogram that shows the clot in the popliteal vein, as well as in the femoral vein all the way up through the iliac vein. So that was what we initially started with, and then the next slide will show you after angioplasty and no stent was placed in the iliac vein, but she was just anticoagulated from here. So that's a good point of discussion there. Next slide, please.
Again, nitrix more.
So now with persistent swelling 2 months out from that, here's a CT scan that it's very difficult to see the iliac vein. The external iliac vein or the common iliac vein, although the common femoral vein on the left is open. Her right side venous system is normal. So once again, her symptoms are swelling of the left leg and persistent pain, and it looks as if she has reoccluded her iliac segment while on Eliquis. Next slide, please. So our plan and what we've done so far is we accessed the right common femoral vein and shot a venogram. And if you could show that, please. Wendy, that first picture. So this is access up the right side, and what you see is a flush occlusion of the left common iliac vein into the IVC. Next slide, please. Or excuse me, next run, Wendy. And then this is with a SIMS 1 catheter, trying to find the access into the left common iliac vein from this contralateral approach, and it's very smooth. You just don't feel the catheter engage with the left common iliac vein at all. Next slide, please. Or next run, just like that. So then we access this left groin. What you see is a myriad of collaterals, and the wire will traverse north. Next run, please. Next run, please. And we can get in these paralumbar collaterals. Next run, please. And then we finally did an oblique run of the left groin there. And I think what we're in a collateral network, and we really aren't in the common femoral vein working our way up through the external iliac vein. So our next strategy now is to access that profunda femoral vein or lower and see if we can come up through the common femoral vein into the external iliac vein more specifically. The other strategy is to pull this sheath way back and see if we can course more medially from the end of where our pre-existing stent is right now. So this is a 5 French sheath in the left groin, and so we're going to try a second access point and see if we can use what we have in there already as a reference point to then deviate elsewhere.
So,
All right, questions?
So Bruce, this is a good point. Just going to ask the panel, Dr. Rosenfield, you're going to direct the sheath back, pull it back down and redirect, or are you going to get a lower access? And any other opinions, please?
I think what I'd do is probably, first of all, I'm not sure why you need to keep it 5. You could go up to 6 or 7 because it's venous. And I'd probably leave the wire up and pull the sheath back and, you know, leave your wire up to secure it and then just pull the sheath back. And if you believe it's low enough to redirect, that's what I would do. But rather than get another access site,
Okay.
that's just me.
Any other opinions? Tony?
Well, I think you got to figure out where you aren't right now. So I think I would probably choose to do a lower access. I think it'd
Lower
give-
access.
Yeah, I think it'd give you a little bit better idea of where the real recanalization is. Is there a stent on that left side?
No, there is no stent. It was
No.
angioplasty before.
Okay.
So Bruce, what are you planning to do? Please share your thoughts.
So what we're trying to do is, if we can get in this little profunda branch here, then that looks definitely where we want to go. And then we'll walk up and stay medial to our reference wire that we have in there with our first sheath. And if we can stay medial to that, then I think we have a chance to orient ourselves where we want to go. Then, once we're able to get across, the plan is to angioplasty and then place a wall stent up to the level of the IVC. However, now that I see how much disease there is low, one of the challenges is going to be how low can we stent from an ipsilateral approach.
Bruce,
So we may have to bring our wire up, snare it, and come around from our contralateral side to actually place a stent down lower into the common femoral vein, and then ipsilaterally we'll be able to place one up closer to the IVC. So you can talk through that. I'll help Dr. Devane here as we're working through this and go from there. All
Bruce,
right?
Bruce, while you get access, I'm going to ask the panel, you know, why wasn't the previous time the lesion stented? I mean, is there a thought? So, Steve, any thoughts? If you would have done it, would you have stented it?
Well, I think that's probably the reason this may be a more of a heartache, because you know that's could have been prevented without a stent. You just know it's going to be a return trip.
Yeah, that wasn't my decision. That wasn't my decision that it wasn't stented. And if you, Phil, if you can roll back several slides, you can show their completion venogram after the angioplasty, and you can see that there is just a significant flow obstruction in the distal common iliac vein. So Phil, roll back several slides.
So Peter,
In the presentation, I think we can get them their answer there.
I'm going to ask Peter. Peter, you do these procedures also, is that right? So
Yeah,
is stenting
forward.
like universal, or there are situations where you would not stent?
Right there.
Yeah,
So this is what they were left with on their completion.
so
So yeah,
Bru-
at that point, I think stenting makes sense. All
so
right?
Bruce, Mike.
So we'll go
Backrack.
back live here.
Bruce, Mike Backrack here.
Yes.
Good case. Good to hear from you.
Hey, Mike.
You know, I think there are a couple of things. I mean, I agree that stenting would have been certainly appropriate at that time. You know, it's likely that this is a May-Thurner physiology, that in fact that vein is very sclerotic, and that it's the likelihood that angioplasty was going to work alone just, at least in my experience, has not been borne out. So I think that was a faux pas on that part. The other, I would tell you though, it's only been a couple of months now that this has been occluded. And again, if worse comes to worse, the other option would be to come from above. So either a brachial vein or come above, where you have a mechanical advantage coming down from the IVC on top of that. You may be able to, even though it looks relatively smooth, with a vert catheter or an angle type guide catheter, you might be able to get enough support to get into that proximal segment of that iliac vein right at the junction with the IVC. And then once you have that directed, it may be easier to get into the true plane where you want to be. So if this doesn't work, I would
That's an
I would
interesting
consider
thought.
that.
So it's an interesting thought. In consideration of that, what I actually did was I put a SIMS 2 in. So a SIMS 2 in my mind has as much support as I can get
Yeah, I mean, this
from
is,
an ipsilateral side. And then the strategy to come down from above, I like it.
so
We'll get
Bruce,
behind
this is
it.
Kenny. I agree. A SIM2 is a really great catheter once you get into the little nubbin, if you will. But the key here is to try to find that nubbin And you actually have your previous angiogram, which you just showed. Their completion angiogram shows you sort of exactly where the vein does enter the IVC. And I guess my experience has been that using something like a coronary guiding catheter to sort of put you up against it and then beat away a little bit, you might be able to sort of create the channel, recreate the channel where it exists. But I don't think a Sims 2, it's very smooth. You said that, you pull it back and forth, it'll just bounce right off. But anyway.
Here is another comment that I would have made. The case, I perhaps would have done an MRV before. Obviously now is not the time to talk about this, but just as an FYI, perhaps getting an MRV before you did the case would have been useful. I think that being in the contralateral side is making your case more complicated than it need to be. If you had had an MRI or other non-invasive imaging that would have characterized the nature of your lesion and or the location, then you would have known from the beginning that doing a below approach in the POP or whatever would have expedited the case and saved you all this trouble.
Munir, go ahead.
So really, we have a lot of those cases in which we hardly difficulty in entering from below. I feel that if we go triaxillate, which means 3 layers with a stiffer wire from the internal jugular vein, you have a much better chance to get in the real lumen.
So you
the
would
problem,
get-
multiple branches there, you don't know where you are now.
So Mehdi, you agree with that? You get access from IJ or brachial to get
I
into
think
this?
that the challenge here is not that he's not able to cross. The challenge is that he's not in the right place.
Sure.
He has a flush occlusion of the common iliac vein, so it's not a support issue for him. Is the inability to know where you are. I don't know if IVIS would be helpful here. I doubt it, to be honest with you.
too big,
It's
too
so big.
It's too big.
It's unlikely it's going to show you.
From
But
this access.
I think Carlos's point is a nice one, that if you had MRV or some kind of imaging from before, maybe would have kind of tell you where your,
This is a good application for if you had a CTV or an MRV and you could co-register with your fluoro, that would be a great application for this. You'd be able to see where it is.
Peter?
Save you time and aggravation in the case.
Yeah. And the other thing is, eventually, once you get the wire across, you're going to probably put some wall stents because that's all we have currently in the United States. And as you know, those sheaths are not very long. So if you're coming from the neck, you might have issues in terms of, are you going to have enough length to actually stent and cover all of the disease segments, because it looks like you're going to have to extend this down into and including a common femoral. So a retrograde left popliteal approach from the very beginning, I think, probably would have simplified this.
The other I don't want to jump the gun, but the other challenge is that when you're deploying those stents from the neck, it's much harder to control them, and they move a lot. So you could end up either not catching the Maytherner, meaning fall short of the bifurcation, or extend extensively to the inferior vena cava and cover the other side. There was actually a recent paper that showed that there is increased rates of contralateral DVT in patients that have been treated for Maytherner, and the authors thought that the reason for this is the lack of careful placement of these stents at the bifurcation, meaning that we are jailing the contralateral limb.
So it's why really go from jugular and then snare it down to the groin or even the middle of the thigh, because you need to purchase, a good purchase really, and deploy from the thigh, never deploy from the internal jugular because you don't know where you'll be.
Who thinks that in this position right now where Bruce is, that trying to access the left popliteal or lower down in the leg is easy? It can be quite difficult, is that right, in this position? It's not easy to do it right now.
No, but you know what? The problem here, though, is
Yes.
that I would abandon the common femoral because, okay, let's say that he gets back into the area where he wants to be, and then he crosses the stenosis. The real issue is going to be that when he places the stent, he's going to miss that lesion there, and then your stent is going to have a problem with the inflow, and ultimately it's going to get thrombosed again. I think that a better understanding of what's happening in that common femoral vein is going to be critical. I would abandon, even though it may be logistically more challenging.
Tony, if you had imaging, would you have planned differently here?
I think that anything that allows you to understand where the confluence is helpful, right? So whether it's registration of MRV or whether it's CT and overlap, knowing where the target is from some way of imaging is going to be much better than trying to do it blindly. And I think, Bruce, you showed very nicely how smooth that contralateral side is. It's not going to be a feel thing. No matter how many different views you go in, it's not going to really show it to you.
Anyone for transcutaneous ultrasound here? I mean, I think that would be something I would suggest. Bruce, is there any chance you would consider that, or you are so experienced with doing
What's
this?
that?
A ultrasound probe right
Consider
on the
what?
skin? An ultrasound, transcutaneous ultrasound right here to guide you.
Yeah, we did use ultrasound access. We got it right here. And for the life of me, it looks exactly like we stuck the common
Oh, I see.
common femoral vein. We are in the common femoral vein that looks like right there.
Yeah, no questions.
Can you show that? Phil, are you able to show our IVIS image right there? See the catheter going in the femoral vein there?
We don't see it yet. Here we go.
We don't see it yet, but we are going to wait. But I think tracking it through some limited ultrasound would actually might
You
help.
can roll out this IVIS or the ultrasound for their camera if
You
you'd
won't
like.
see much, Kenny? Not useful? Ken says it's not going to be very helpful here. Mehdi, you would use some ultrasound on the skin here, or
I
not helpful?
think to get the access is maybe helpful because it would maybe tell you that if you're in the
more
common femoral vein and you did it already, but above that, I don't think it's going to be useful.
So why not to go from the femoral vein? And we do that a lot, really, even in the middle of the thigh or a little bit higher near the adductor canal, because it's very superficial, and you can have very good birches there, and it helps a lot
So let's look at this ultrasound carefully.
because you're in better channel.
They're in the common femoral vein.
They're in
The
thing-
problem
yeah.
when we open those veins surgically, there are so many channels. You don't know which channel you are in, because
All right.
we do endarterectomy for them, and you see tons of channels in that area.
So you say that at
So,
the level of the common femoral, you
Maybe
don't
what we
think
can
it's
do is
true.
take our, if we had, with this Sims 2, we keep vacillating back and forth between that left groin, and here's a straight AP. That to me looks like it's starting out pretty good. Maybe it's a little, maybe we got to go medial down in here someplace.
We could
Let's
look at
try
the
working on the
previous,
straight AP.
Bruce, look at the previous,
We ought to hit something
their
firm right
completion
there.
shot.
Have it straight, stiff glide wire, please.
Bruce, are there, Dr. Rosenfield just suggested looking at the previous angio and some sort of calcification, something to guide you where it could be?
Yeah, we don't have that here. I just had that on a CD.
All right.
That just doesn't, it's just too easy going through that. Maybe what we can do is come back up here with our Sims. There was one area, if you can give me like a, got like a little confianza, please? Let's see if I can just poke with a little confianza
So
stiff wire.
what wire do you
where
have
I
right
think
now?
it is up here.
Bruce, what is your guide wire you're using right now?
That's just a straight stiff glide wire there.
see.
We had a Roadrunner. We've had an angled Advantage glide. And then I've tried, as you can see, the Sims comes down. It's hard to even see where it is. So let me up the mag a little bit.
Bruce, do you think the Sims loop is
too
keeping the tip of the catheter away from the... It seems like it's not helping you, I don't know, at least from these images. Like that loop is keeping the tip away.
Yeah, when I had the Sims 1, it didn't reach me either. I could try, give me a regular sauce. How about a regular sauce? Let's try that.
Not stiff enough.
Or even RDC.
There you go. Guide catheter.
The loop is a little big.
This doesn't seem to catch on
Yeah.
anything.
Yeah, I think Mehdi's point is right. If you look at the angiogram, the tip was off of the wall. I actually think it's a little bit lower than that.
This may actually be a good one for a steerable sheath like the Destino, where you'll be able to hold that angle and do a little gentle pecking with some targeting from your previous angiogram.
Yeah.
Guiding catheter.
Bruce, can you
That may be a
suggest
good thing
to
to
look
try
at the
next.
prior angiogram one more time, whenever you have a
He
chance?
doesn't have it.
No, he has one picture of it.
No, he doesn't have
Oh,
it.
he doesn't have it. Okay.
What about a renal RDC or a renal guide catheter that you could actually point that direction and just kind of beat away at it with the tip of your wire, and you probably get it.
I'll need a wire to exchange out for that sauce.
I mean, from the right side.
Bruce, as you're probing that occlusion, what does it feel? You feel you are in the right place?
No. No. We haven't
It doesn't,
We haven't
it's fairly lateral right
hit
now.
something that feels like it's the right thing yet. And this,
Hey, Bruce, at what point are you going to consider another access? Because neither of these two strategies is getting you anywhere.
look at that sauce. Yeah, we've got,
Angulated?
that's
views
why
will
we
help here, guys?
stuck
Anyone?
that left groin a second time. You know, I can count on one hand how many times I stuck that, a groin like that, twice. That was,
Bruce, we are trying to
Not
be
ideal,
helpful
I
here,
don't
but any chance of taking an angulated image here? Anyone on the panel? Or you think it's a waste of contrast?
I really think if we go from jugular, because we have a lot of those, because the channels don't meet. You think you are in the same area, the channels don't meet. So internal jugular is the last option, or something like that, right? Or
Yeah.
it's too large for Sims 1 and too small for the other one.
I would just flip
that
the
just
patient.
seems too low to me.
Too low. That is low.
That's just too low. Here's the,
Seriously.
I come in right underneath here, right there. Have that, confianza. So I'm sorry we're logging away here.
Please, this is really, really educational. So please, we are watching you with great intent and interest. So please continue. And please share your thoughts as you strategize the next step, because the audience would definitely like to hear it from you.
Bruce, if it were easy,
This
you know,
feels definitely different.
It were easy, it would be
I don't
boring.
feel- I feel a lot more. I don't think this is
And congratulations for taking on such an incredibly challenging case. I think
Yes.
these venous cases are actually, in some
that looks
cases, more
interesting.
challenging than the arterials.
like that.
This is a
Far
branch,
out
you
on this
think?
one.
Yes. Looks like a branch, too horizontal. Anyone who thinks this is the nub? No? Munir? It's too high. It's too high. Carlos, any thoughts of wisdom here?
No, as I said, at this point, I really think that either going from the neck or flipping the patient over will be my next step. I think that we're asking for complications here.
This is probably the promising spot.
What's that?
That spot looks
There
promising
it is, right,
to our
that's the
panel.
place, right there.
You got it.
That's where we want to go, right there.
Yeah.
That's where it should be.
And you're probing it with a confianza?
Yeah.
Again, the loop backs up, I think, the support. Maybe a rim with a shorter, tighter curve.
Have a prograde catheter, please.
I think you crossed. Beautiful.
think that close to that other catheter.
I think we're very close.
Bruce, it is a little hard to see with the contrast hanging there. Could you say a few words? Are you very close to the previous channel, or you can advance a wire in your previous sheath on the left groin?
Like, this kind of just feels right. This feels right to me. It looks right to me. It's at the, look at the iliac crest here. This is where it should be.
Okay.
Right here. That looks right to me. Where our wire's coming down looks right. If I can just put a catheter here, get a little bit more support. I'm trying to just push the confianza a little bit so I don't buck the sauce out. Thanks for that idea, Mehdi. And then get a little more support inside this catheter. So the telescoping method, just keep stacking one big or smaller thing on inside the other. I think what we'll do is stay with us for another couple minutes and see if we can get across this. Then we'll cut to the AAA, and then we'll come back. How's that?
That's perfect. That's perfect.
So if the AAA can get teed up, I'd like to show you if we can cross this, because I think once we do that, then it's just straightforward after that.
Just as your thought, how low do you want to stent this?
Well, that's going to be the big question I had from the start as well. On the CT, it looked like the common femoral vein just to the inguinal ligament would be good enough. That's why I thought accessing that left groin over there was not going to be a big deal. So
Anyone in the panel has a comment on that? How low would you stent, or you'll cover all the way? I agree with Bruce. Any other thoughts, Dr. Baccarat?
Yeah, so Bruce, since you just have a small wire through, is there any chance that you can just snare it from below and then do a pull through, and then you can put whatever you want over it? I worry that you're...
Yeah, I just want to get this, I'm going to put this prograde catheter in to get just a little bit more support, and then we can do anything we want like that.
Yeah.
So here comes this 2.8 French prograde. If that'll pop into there.
Within a mother and daughter. Yes. Yeah.
Oh, hold on. Let me get my catheter up there first. All right. All right. Now let's see if the wire will go. A little bit more wire.
Yeah, he's got to get it.
If you pull back on that catheter, it'll probably give you a little more support.
I said just quick cross rate.
There, now he's pulling down. Not too much.
Yeah, now's when you want that Simmons, huh?
Yeah, but that's true. That feels like it should. That's the trouble spot.
Would you
Once
ever
we get
consider
that
Bruce
catheter through
ballooning
there,
it a little bit? The ostium, just with a low profile balloon?
Yeah, we could try that.
This is a 2.8?
It's a confianza
Will that
profile.
wire go?
Is this an 018 or 014 wire? Just put
0.4 confianza.
just put another wire through it alongside it. It'll give you the support.
Will that wire go just a little bit more?
Trying this.
Now he's got prograde.
You can put a wire up from the other side and see if you can connect it.
Correct.
Are we if we're in the same plane that we can snare it.
If he could...
This, and then the hardest part of the wire is traversing into the proximal external iliac over there. Let's see if putting a wire up this other side we touch them.
Yeah, he's
It's very close.
He's caught up. Yeah, he isn't all the way down yet.
That's in the same plane though.
Bruce, from this angulation, from here, it looks the wires are not too far.
Sorry, I'm schizophrenic when it comes to steering this camera. That's got to stay lower. Yeah. But it isn't in the same in quite the same plane.
I think the wire antegrade is at the external, and the other one is very close to the ostium, but it is deviates superiorly.
You give me a, pull the prograde out. Leave the wire, pull the prograde. While we keep working on this, why don't we shift to Dr. Gandhi over in room number 8, and they can get started. They can get started on the AAA, introduce that, and then we'll keep working away here. How's that?
Perfect, perfect. So that people don't get bored with my voice. Anyone in the panel want to moderate one? Tony, you want to?
Hey, hi guys, I'm Sagar Gandhi. I'm one of the vascular surgeons here at Greenville Health System. I'm here with Dr. Jones, one of my first-year fellows, Allie, Kevin, Allison, and then outside we've got Harley and Melissa. We've got, we can start with our case. We've got a 76-year-old gentleman with an abdominal aortic aneurysm measuring 3.5 centimeters. He's a heavy smoker with diabetes. He's on aspirin and Lipitor. He has no claudication, and he had a recent cardiac cath that showed 3-vessel disease, but it's planned to treat medically. His creatinine is 1.23. Next slide. So just looking at the scan, a few interesting things about this is he's got a heavily calcified aorta at his proximal neck. And also, if you look at the aneurysm itself, there seems to be a significant amount of calcium in the lumen. Pretty good access vessels, not very tortuous bilaterally. They are a little bit small. And he's got a patent IMA. Our plan today, next slide. Plan today is bring the patient in for endovascular repair with spinal anesthesia. We already have our percutaneous access using ProStar for pre-close method. We've given him heparin, and we've used a marker catheter. We've shot our initial shot, which we'll show you here in a little bit. Our plan is to IVIS because of that calcification in the aortic sac to make sure that both of our wires are in the same portion of that aorta. Plan is to use a gore excluder graft, 23 proximal, 12 millimeters, or I'm sorry, 14 millimeters actually from the left, and then we'll post-dill with a Q50 balloon, and then we'll show you the closure of both groins if we have enough time. So if we can show the aortogram. Can you play back the aortogram, please? So as you see here, we've got the catheter. We've already got our 16 French in from the right groin and our 12 French in from the left, the 16 French to deliver the device. You can see our renal there is at lowest renal is at L2 about. And we've actually got that marked, and we've actually cannulated the renal so we can know exactly where to place the main body. Next thing we're going to do is we're going to go ahead and plan to IVIS. And so what we'll do here is, can we show the IVIS catheter as well, or the IVIS feed? All right, come on, live. All right, we're going to send our IVIS up. Pin wire, please. So here we are in our proximal aortic neck. Heavy calcifications. There's our, you can go up a little bit and you see your renals come off. Our right renal there, coming down a little bit, and you'll see your left renal right there.
That's left.
And so because of the calcifications on CT scan, we wanted to get a good measurement. We can go ahead and measure there, please.
Very nice IVIS images. Thank you.
And based on our preoperative imaging, the CT scan showed a good length on the neck, which was about 2 centimeters. So I think we'll have good seal. We just want to double check. Yep.
So Tony, in your experience, IVIS
Thank
and
you.
the CT measurements
And so
are
that,
pretty coincident, or?
so that confirms what our
You're saying
preoperative
no?
imaging showed with our CT scan. That's good, thank you.
So Peter, that was the next question.
And so we'll just follow the, go live please, with the IVIS.
Peter, can you
Thank
talk
you.
about IVIS
And so we'll
CT
just follow the
correlations when he's done?
Yeah, I was just telling
aorta
Mena that,
down, and you can see some of that calcification there.
Our our good friend Venki Ramaya at
As
the
we go
Arizona
through.
Heart Institute is a very big proponent of IVISing. He does a ton of aneurysms, as you know, and Venki loves to IVIS all these with the
There's our aortic, or our
with the 035
bifurcation
Phillips
there.
system. And he does it for two reasons. Number one, the reason why they're doing it, just to make sure that
And now we're on our common
CAT scan
iliac here.
images, CAT scan
And in a
images
moment, you'll
and
see
what
our
you
internal
have
iliac
at
come
the
off.
time of the implant are actually saying the same thing in terms of diameter.
Right there.
And also to look
All
at
right,
the
so now we're
calcific
coming out with
burden.
the IVIS catheter. We already have our main body open. All right, hold sheath.
And then the other issue
Actually,
is
let's go
it
ahead
can be
and drive
helpful
our 16
if you've got a
French up
shorter
now.
neck and you're trying to decide if you're going to use an aptus
All right, got wire
endostaple.
there.
That may be another potentially useful use of the IVIS to help you with that decision.
We love your IVIS
So the
images.
next thing we're going to do is drive up our sheath to the proximal abdominal aorta so we can safely deliver our device.
I think
You
we'll just
know,
wait to listen.
one of the other interesting things about this case is, you saw that distal aortic bifurcation was pretty
I'm going to
tight.
take my catheter out.
And that can certainly be problematic depending upon the specific type of graft that you're using. So, some operators, for example, if it's tight at this bifurcation, will like to use an AVX endologix graft
Go ahead and walk that off.
because it saves a little bit of
All right.
room in there, and you not have competition between the two limbs.
All right.
Actually,
All
I
right,
just
so
heard he
next
cannot
what
hear
we'll do
us.
is take
so
the
I
main
think
body.
That's why he's speaking over, so I think he can't hear us. They are trying to
That's
fix it.
gonna be
so
a-
sorry for that. But we will just listen to him and follow the operator.
So we use IVIS at our institution for all of our endografts, and it's been very helpful both in sizing as well as reducing the amount of contrast exposure that we have. It's probably the best way to determine that you're intraluminal when you cannulate the contralateral gate. And there are a few times where we do adjust the size of the device that we choose based on the IVIS. So although we do all of our measurements off CT originally, now, of course, in the old days, CT wasn't very good. Now with our multi-slice scanners that are so much better and Terarecon and so on. But we still often double check, so it's sort of a belt and suspenders thing. So every once in a while we'll find one that we're concerned about infolding, that we've gone too big, or that they think perhaps we've undersized based on the CT. So we find it very helpful.
Thank you, Munir. And then Steve, you have any thoughts after Munir?
So really, I use IVIS in aneurysm only if there's a suspicious of a problem in the neck. That's the only time.
That's all.
Because you are wasting $1,800 in a case. This is a lot of money. And when we started learning about IVIS, we used it, but we found it did not make a difference at all in the procedure with a very good CAT scan.
Anatomically, this is a great case for any device on the market. So I don't know about the utility of the adjuncts like IVIS, but I think it's a great instructional tool today. But to be honest, I probably would not have selected that for this particular anatomy.
Maybe that at the Shark Tank, they presented a device for orienting and co-registration. Remember they use in Cleveland Clinic. Have you used that, or the surgeons use it?
I think Subhash is talking, we had an innovation summit Wednesday, pre-symposium, and Centerline, as you recall, Roy Greenberg was one of the pioneers of the Centerline system. So the argument is with Centerline that you reduce radiation and make the case more efficient. I think it may be helpful for more complex fenestrations and complex disease, but I think for a straightforward AAA, I don't know, Steve, what do you think, Steven?
No, similar thoughts. If you've got complicated fenestrations and you're having to do a snorkel or a chimney, or you're really pushing the IFU on some of these cases, you want to use every adjunct.
Let's go ahead and get the angle applied.
While they're working, any thoughts on the selection of a closure device? They selected ProStar. There are certainly other options that many of us favor. Any
Back
thoughts?
up one more, please.
We use the pre-closure, two of them only. Yeah. Two in different angles, the closest most everything.
Yeah, it's less of a dissection down on the skin. Patients certainly appreciate it postoperatively, two ProGlides as opposed to this big honking.
So we were part of the MANTA trial, and we had very good results with it. I think that it's certainly, I think it's going to be useful. Is it going to be for every case? No, but I think it, you know, there's basically two separate, one for up to 14 and one above 14. And I think where it's really going to be helpful, and one of the places where we've had difficulty is in the contained ruptured aneurysm or a hypotensive ruptured aneurysm that you're trying to treat endovascularly. Frequently it's a scramble, you get in access, you're trying to get a balloon up, you don't have time to do a pre-close, you're futzing around. And that's a situation where if you have to cut down afterward, it's a total pain. You're often too low, you get the lymphatics, I mean, it's a problem. So the MANTA device in that setting may very well be helpful. And I think it also will help many of our cardiology colleagues who are using the various catheter support devices, you know, the Impella device particularly, because we've seen at our labs, we've seen a number of pretty significant vascular complications, and then they come to you afterwards and say, hey, can you help me with this? How can I get this out? And so they've reinvented the wheel of complications, at least in our experience, and the MANTA device may be able to help us with that. We're looking forward to having it available.
Carlos, I want to get you into this discussion. Any preference of various devices that you would use and something that you have personally is your favorite?
No, I think that as everybody has said before, any of those devices, this is a perfect AAA, good landing zone, neck is good. I agree with Peter's comment about the tightness of the iliac bifurcation. The comment about the IVIS, I do think that routine IVIS is of utility. I don't know that it's that particularly expensive, and you'll be surprised in some of the cases. In terms of the closure device, I appreciate the use of per close in a case like this.
So, Mike, when is the MANTA device expected to be available in the U.S.?
You know, I don't know. I haven't been following I mean, all the things have been submitted. Obviously, the trial's been done for quite a while. The initial paper came out. So I don't know where we are from a regulatory standpoint. So I think our hope was that it was going to come relatively soon, but I don't know.
I had a question for the panel. From a standpoint of cost saving and reimbursement for these endografts, my understanding is that it's very tight, your margin. There was a time that, you know, folks used to do cut down, at least on one side, to, you know, kind of offset the cost. Is that now resolved, or what is your recommendation related to that?
So that it's been resolved, at least in the mind of the CMS people. So what they've done is change the codes. So what was happening was they differentiated between an open cut down and a pre-close technique, although depending on how you dictated the pre-close technique, we had people that were doing that, calling it an oblique femoral cut-down incision with 2 ProGlide devices, and they were billing it as a surgical, which at the time was probably, but currently that's now passé, because what's happened is they initiated a new code, so as long as the sheath, I think, has to be at least 12 French, then it's, so there's a separate code. But there is a separate code. If you truly have to cut down, isolate the artery, for example, and do a patch repair, or you do a femoral endarterectomy in association with that, or an interposition graft, those all get billed separately under a surgical code. But now they've just put one code and lumped it all together, so now it's not an issue.
I think it's still actually surgically open, you code it different, but if you do bear close, it's part of the procedure.
I just want to indicate our operator, you know, that's important for those who are doing it and not as experienced, is to find the right angle to wire it. You just saw the clever manipulation of finding the right angle and being able to. Can you speak to it? I don't think you can still hear me.
So now we've cannulated our gate. We used a combination of an angled glide wire and glide calf. And now we're going to, multiple ways to confirm whether you're in the endograft. One of the ways we do commonly is we take up a pigtail catheter and what we call spin the pig. So what we'll do is take that up, we'll mag out one.
If your IVIS is out, that might be a possibility.
Okay, great. Go ahead and pull the wire back a little bit, please.
That is probably the best way to do it.
Yeah, we would just IVIS it. I mean, you can tell absolutely if there's no doubt about it then.
The other thing with this particular orientation is there's some overlap of the limbs, and that makes your life harder.
There we go.
So if you're deploying these and setting it up, make sure that you splay out that bifurcation as much as possible
Take this
to make
up.
it extremely obvious.
And we'll get the, let's go ahead and switch out for the stiff wire now. So typically we like to do that because what we'll do now is take the marker pig and we'll do a length run to decide what device we want to use as far as length. The diameter we've already chosen is 14 millimeters from our preoperative imaging. Set that up. All right.
Okay.
So we will put that there. Okay. Let's go ahead and come down and go into a RAO. There we go, and then take cranial out. Excellent. All right. Then come on down a little bit. There we go. I like that. Good.
Very good
Okay,
angulation.
so we've got our sheath back. Just make sure we can see our internal iliac artery. And we'll take a little sheath shot here. Alrighty.
Nice.
We'll go ahead and mark it. Take our measurement. Can you freeze that there? So we'll ask for a 14 by 12 device.
Do you all agree with that?
Next thing we'll do is we'll actually take our sheath up.
It's little.
Go ahead and hold the sheath there. We'll take our pigtail off now.
14 by 2.
This is just to make sure we can
it
safely deliver our contralateral limb without getting caught up and kinked on anything.
Actually,
All right, that wire there. Take that off. All right, we'll take the 1412, please.
so when would you actually use a longer one?
Yep. Yep, take that first. Is the device open yet? Ali, why don't you go take the device and then have Kevin.
One thing about a lot of these devices is that wire doesn't take a center line measurement, as Mehdi was talking about earlier. And so sometimes you'll miss a little bit, especially when you cross, because that adds more real estate.
So that's why I was asking that because it looks perfect, but it could be slightly short. Dr. Bacharach, you have so much experience.
Our experience with is that the main device is often just a hair long,
Yes.
and the contralateral device is always a hair short. And just because of the Torchwoski and so on. And so we have we've gone to sort of a pullback measurement as rather than receiving. Yeah. And it's and that too is and again the devices are relatively forgiving. You can often push up a little bit just to be certain if you know where the hypogastric is. So it's but you're right, if it's a borderline, we'll often take the device that's just a little bit longer.
16. Oh, I see. What is the so that is the next length? 16.
So it would be 10, 12, and 14.
14.
14. So it's a total length of 8 inches.
I see. So device size is 14. You can avoid completely the hypogastric here, is that right?
Was that?
You can avoid it, the hypogastric, completely.
You know, I usually go longer than shorter because I can manipulate the longer a little bit, almost half a centimeter. You can.
I'm going to ask maybe 12 by 14 your choice too, and land it just above.
One more.
I think the points they raised are good ones in the sense that, as Dr. Bacharach said, you can manipulate these graphs now.
Make sure it doesn't.
So you have a little bit of a leeway around the landing zone.
Nice.
She marked the wrong screen.
For those of you that
Play
don't do
that
a
through
lot
one
of
more
this,
time, just to make sure now.
for those of you that don't do a lot of this, it's also extremely helpful to mark your iliac crest, because invariably somebody's going to move the table and it's hard to make an angiogram and find your hypo.
I think they'll do it again.
Okay, come on live. Come live.
It would be so good to have technology to mark it on fluoro on the screen digitally. I think that is one technology that is begging to be answered.
There's some actually a ruler you put under the patient.
Yes,
You
yes.
can move that. So that's okay.
That's one way to do it.
So we'll slowly deploy this and push up just a little bit to make sure that we land that internal iliac exactly where we want to. You can usually typically get about a centimeter
Is there some
Give or
force
take.
shortening or not much?
to do that.
Not in this case, is that right? We don't
Right on
expect
the
much because it's
thing.
fairly straight and not much angulations.
Yeah, it's straight, there's no.
Okay. All right.
Right on.
So we'll take my device out, and we'll take the
You see the
Q50
bifurcation
on my
of the
side. Let's
calcium,
go
you
ahead
see
and
it.
pull your sheet back. So I've got your device here. Put your sheet device back. Yep, there we go. Get a little bit more. There we go. All right. Let's go ahead and finish deploying your device. Kevin, if you can walk this off. So first thing. So then we're going to make sure that this is completely deployed there, or unconstrained. We lose constrainability here. You don't see anything there. And the last one twists off, and our iliac limb deploys. Okay? So now I'll hold the sheath. Come off with the device. Uh-huh. Beautiful. All right, I've got your wire. Okay, go ahead and flush your sheath.
Oh.
Okay, keep coming, walk it off.
I think Tony has a good point. Where is the left sheath? Is below? I'm pretty sure. Here it is. Yes, yes, it is.
Q50 on my side. Guys, the wire's on. Come on, line. Okay.
Looks kinkly, you know? You do.
Okay, let's go up to the proximal.
Okay, there went.
Center that up, please.
So proximally, first.
Straighten this out. Okay.
Low pressure.
So now we balloon our proximal. All right, we'll come back. We'll actually, for this case, hold this sheet there. For this particular case, what we'll do is we'll actually balloon our bifurcation as well. If you note on the IVIS and the preoperative imaging, it was a little tight, so we just want to make sure we have.
I just want to remind we are coming to the last 30 minutes, so I think there's a third case too. So I think you're doing excellent work. Fantastic display of this. Very good.
All right, thank you guys. We'll send you over to Dr. Gray now.
Thank you very much. Thank you.
Come on back. All right.
Bruce, we are back.
Well, we've made tremendous strides here. So this is one of those little micro Cook 3 balloons
Coming down.
we haven't got our wire over there all the way yet, but we've got a little bit more purchase. Now we have a 6 RDC sheath inside our 8 French right groin sheath. And then that's That's an Ironman wire and catheter that's moving down there. That's good. More support. Let's see if we can get our little micro balloon further too.
Yeah, that'd be great.
So
What size balloon do you have supporting that wire?
all right. Now we're going to see if we can get this.
Hey, Bruce, this is Kenny. I'm just wondering if you had any luck with just folding over a hydrophilic wire like a V18 or a even a angled stiff glide wire and just sort of, you know, beating away at it like that. I'm just wondering if that's something that might.
We're close to that step. Let me see if I can get my catheter just a little further and get that straight, stiff glide wire.
Yeah.
I think that balloon will go just a little bit further.
Let's make that, put that stiff wire in now.
All right.
And Dr. Bacharach
Sorry, it's been
suggests.
so exciting here.
There you go.
Excellent.
There you go.
There, yep. Let me see if I can get catheter to follow back up some.
Which wire is that, Bruce?
What's that?
Which wire was that you tracked through there?
That's a straight, stiff glide.
Yeah, perfect.
And
But we had to dilate. This is a little micro. Let me just describe what we had to do. I couldn't even get a little 2.0 prograde to track over our original Confianza wire. So we took one of those little micro Cook balloons and dilated just the ostium there. That's what you see. See a little marker right at the branch point there? A little marker. That's a little Cook micro balloon. And so that gave us a little crack there. Maybe I'll just pull that out now. That's not helping us much right now. So that's out of there. All right, so Phil, can you show this, So this is the little Cook micro balloon. It's really dinky. Once you take it out, you can't put it back in again because it doesn't have a whole lot of axial strength, but it's really good for tibial stuff, and I can't ever remember using it in an iliac vein. So, all right, now that we got this, and we got our, let's see if we can get our sheath over a little further.
So I'm
Get a little bit more support.
Bruce, I'm going to ask our panel a question while you wire this through. For those who are not as experienced, and say, imagine they are going through and they've crossed this proximal iliac occlusion, how would you suggest they actually confirm they're in the right place before they confidently advance their big sheath? Should they do some IVIS? Because now the vein is constricted, you will see the walls. What should they look for? You inject some contrast, it'll destroy this area, you won't be able to work. So what are the options that are available to operators?
there we go.
I don't think IVIS is going to help, in my opinion. I think that in this situation is the feel of the wire. So knowing that how the tip responds.
Can I get a 6 balloon, please? On a give me a microvena wire.
Knowing how the wire responds, I think that's helpful. Obviously, the one that a lot of us use is to have a support catheter come over the wire and then take a picture to make sure that you're in the right place. That's another one. I think those are the two. I don't know if I'm missing anything else,
Or maybe advance the wire from the other side and see if it comes close. I mean, get some guidance, or you don't think that's useful?
I mean, that one you have to be careful.
I'm
because they
going to
have
dilate it
multiple-
all from this side. Well, I got the sheath over pretty good. I just want a stiff wire in now, so I can get some more, so I can get some traction to get it opened up. We can still use our left access site if we to put a stent if we need to. We haven't lost that. So this here is a 035, if I can get this over there, we're golden. Yeah,
That's perfect.
yeah, very nice.
Bruce, I just want to let you know we have 27 minutes left.
We're going to get this done in 27 minutes. Lord willing. 6'6" or longer. 6'4" is fine. I need a long one. Give me a long one. One that's like 6'6", 6'8". Please. So, I also like what that common femoral vein looked like there.
It looked okay, yeah.
It looks like we're not going to have to go down really low.
Yes.
What kind of low? I'll give you a little run right here.
Actually,
All right.
I'm not sure this is normal, the common femoral.
What's that?
I don't think the common femoral is normal. I'm not sure this is the main common femoral channel, honestly.
The collateral network seems to be just a shade higher. You don't think so?
Yeah.
That's what I think. I mean,
Okay, go ahead. Flip back there and come on back. Okay, great. Well, guys, we just wanted to show you our completion imaging after we've ballooned everything. And so if you look at the final images there, looks like we've got landed the left renal very well. We've landed both hypogastrics well, and everything looks good. No evidence of endo leak that we see there. And now we just closed the groins up. Thank you guys for...
thank you. Thank you again. Great job.
All right, we just got a 6mm balloon here. So just kind of see how this looks with it. Just up and down. We're just going to go up to 8 atmospheres of pressure, bring it down, see if we can make a channel here. This is really, for not being a very old occlusion, it's mean. Again, for
I think Dr. Bruce is using an undersized balloon. I think that's the right way to slowly expand. Bruce, can you repeat the dimensions of this balloon? 6 by 20?
This is a 6 by 6 balloon.
6 by 60, okay.
So Bruce, as you're going through this, certainly I think it's reasonable to undersize initially, but you know, one of the critical issues and the things that we as interventionalists have been criticized for is that often when we do stent these May-Thurner type cases, that in fact we undersize the stent. And so I'm curious as to what your thoughts are and comments as you go through that algorithm in your own mind as you decide, you know, how should I stent this? How am I going to size this? How much do I protrude into the IVC to make certain that, so just give us some idea about your thoughts. Obviously, you're a very experienced operator. You've done lots of these cases before, and this has been a challenging one. So give us and the audience a little, what's going through your head?
My initial strategy is if I had to stent down low towards the inguinal ligament, I wanted to put that stent in. I wanted a 14mm down by the inguinal ligament. And then I was going to come retrograde and put a 16mm stent up into the IVC. When you expand the wall stent, you flower it out and then bring it back to exactly where you want it. And if you have angiographic landmarks, you kind of know exactly where you want it.
Any other thoughts on
let me
sizing?
advance the balloon.
Yeah, isn't that now the agreement better to go with a much larger balloon before you put a wall stent to avoid?
Oh yeah, no doubt about it. Before I just wanted a balloon to show. Now I feel convinced I'm in the right spot. If I did that with a 10mm balloon, which is what I want next, please. If I did that with a 10mm balloon to begin with and I was in the wrong place, I would have felt bad.
And now you can see the
I like where I'm at
vein
here.
better. You see that? The common femoral vein is now better, and that gives you a clear landing zone. You don't agree, Munir, yet?
No, I really think it's not a common femoral vein. It is either organized or the wall is scarred or something, so it's not a normal vein.
I see.
A normal vein is huge, the common femoral vein. And the other thing the other thing I usually use a very long balloon, 8 to start with, even 200, so I don't have to keep dilating. And then we put the stent the way it's needed.
I agree with those comments. Those make a lot of sense.
Sorry, back to the sizing of the vein. You can never size a chronically inflamed vein. You don't know what is the size originally. Whatever you size is not known. So you go really, what is the size of the other vein, almost, and go with that if you want.
So how many of you will actually do that? Measure the contralateral vein and size it, or just pick an empiric 16 millimeter?
Or empiric, actually, yeah.
I get worried with the chronically occluded veins that they're really not the same size, and you can't make them the same size. So I think the strategy of progressive dilatation is really a smart and safer one. This is a little different, but you know, perfection's the enemy of good here.
So
sure.
Kenny, how will you deal in this situation with the origin?
Pressure on this
Of the left, of the left common femoral.
Yeah, well, I think that the approach, if he's going to stent, you almost have to stent. I mean, Bruce talked about stenting the femoral segment or the iliofemoral segment coming from the contralateral side, and then the ostial segment, the IVC portion, from the coming retrograde or antegrade rather from the left side, because that's really the only way that you're going to be able to nail it and to get it. Otherwise, especially in a situation where you pick a fairly large wall stent, and then I might take an 18, but you're never sure where that's going to end up. So you have to know where you're going to place that ostial segment. And the only way you can do that is to come antegrade.
That's the point. So, excellent. Thank you for clarifying that.
There was an interesting paper recently on how frequently wall stents are oversized. How frequently wall stents are oversized. The larger that you use, the more likely it is when you go back and IVIS it how small how undersized it is. So there's a fine line between getting it opened up nicely and being too big. So I'm using I'm going to walk it up. Give me the longest 12 millimeter balloon we got, please. I'm just going to walk the balloon up and then use that as a frame of reference of what we get here. Go again, please. And then I'm a little bit leery. My original strategy was go to 16 up top. I don't think I'm going to get it to go to 16. I'm going to be happy with maybe putting a 14 in up top here.
So maybe we should try to find from the panel, Subhash, how many people would go right into the IVC? Because I think I might go into the IVC and jail the right side. I don't think it really matters. I think the flow is going to be maintained. But I'm curious what my colleagues think on the panel.
Carlos, can you start from there and go to Peter and then Mehdi and go down the panel?
Of course, I would agree with Kenny that I would just go up into the IVC and stent it backwards. Yep.
You will cross the right.
Yes, I will cross it. I don't think that'll represent a problem.
Yeah, I don't think you're going to have a choice but to cross the right. Otherwise, you're not going to cover the inciting lesion that caused all this problem in the first place. You have to make sure that you cover the lesion. So you have to, by definition, extend it into the IVC. Kenny and Mike's points is very well taken, though, and that is, with the wall stent, which unfortunately is the only stent that we have. We don't have any dedicated venous stents available in the U.S. And you have to progressively dilate that, because if you take a really big wall stent and you haven't adequately dilated that segment or prepared that segment, you might be very surprised where your stent lands up. you're going to have potentially a lot of elongation of that stent. So it's really important to just progressively and painstakingly take the time to just, in a stepwise fashion, dilate that so that you're fairly close to what you think your final diameter is before you actually deploy the stent.
Yeah, you got it? Okay.
No, I agree with everything they said, except the only thing I would add is that also the wall stent, the distal 1 centimeter to 2 centimeters is actually much weaker than the middle of the stent. So if you just try to be cute and land it at the, the bifurcation, you may not get the radial force that you need. So I think, as Kenny said and everybody else, that you have no choice but extending it. I mean, I think we don't have a good technology for this situation.
So the literature actually from Peter in England, the
Here, this wire looks
982,
really pretty
always
good
in
down
the
this-
IPC, always.
Down this leg here, I like where it's going. All right, let's dilate that.
So, I mean, we certainly put it up to the level of the IVC or a portion up there, but I try and avoid, and often the IVC, the confluence is wide enough that you can place it there, effectively deal with your stenosis, and not completely jail off the opposite, the contralateral iliac vein, because then it becomes a real problem if you ever have to get access again. So I'm reluctant to just willy-nilly put it up high enough in the IVC to essentially jail off that, but I think you do have to go into the IVC for a few centimeters. But again, the confluence is usually wide enough that it'll stay there without, and you still have room to get by on the iliac vein on the other side.
That is what we have done in a few cases, is to not to completely jail it, but actually have it flowered in, if the right side is perfectly normal.
I think you're, then you're hanging struts into the lumen, and it doesn't matter, but I also think it doesn't, so Mike says, so what? But I think, so what if you put it into the IVC and get good apposition? You can go through the struts of a wall stent and spread it. It's a woven stent. I just don't see the downside.
Steve?
I think I definitely echo the idea of trying to keep your options open for next time, if there is a next time. And also to kind of touch on the kind of similarities of this whole idea of vessel prepping that we constantly harp on in the arterial system. This is a different art form altogether. So you have to really have a different touch here. But you do have to be persistent.
Tony, into the microphone, please.
Not a lot more to add other than the hardest part of this case that Bruce was able to show us very elegantly was getting into the osteal occlusion. So to lose where that ostium was without crossing it, I think would be, a injustice. If there was thrombotic occlusion later, it's potentially going to be at that diseased segment of the common femoral vein, and that way you'd know how to get to it from up above. So that's what I would favor doing.
I think we are all advocating covering the ostium. The question is whether you will extend it into the body of the IVC and cover the origin of the right common. But I think, is that it? Tony, you would go into the IVC then? Yeah, is that correct? I don't think you need to jail the whole. So Bruce, we have, I and Michael Bacharach and Steve are for just covering the ostium, have a few millimeters into the IVC and not completely jail the right. But most of the other panelists suggest that you go through and cover and go into the distal IVC and jail it, and it shouldn't be a problem, I agree. But what's your thought?
I like to take the wall stent into the IVC and then very partially deploy it so it's totally flared out to that diameter, and then bring it back till it protrudes out in the IVC just so where it's covered. I don't like to cover the entire right side. So I'd like not to do that if I can help it. I want to pull this balloon back a little bit, dilate again, please.
Munir?
So, Bruce, question. The problem
No,
with
I would extend it beyond the midline for sure. I don't want to come back beyond the midline. Now I'm watching this balloon. The rent in this balloon tells me how far I got to be.
Yes.
So that rent right there, I got to be in that part of the spine. I got to be beyond that. So I would extend it to where my marker is on the balloon right there. That's how I'd put it in right there.
So the problem with the wall stent, it does not mushroom the wall stent to its maximum diameter, because the narrowest diameter usually affects the maximum diameter that we mushroom it. So that's the problem with the wall stent.
see if we want this 12 balloon out. That was with a 12, pull the balloon, leave the wire. Not fully deflated, re-burp it.
7, 8.
Okay, we got, looks like 10 or 12 minutes to get this stented, right?
Yes, yes.
So I'm thinking like a 12 or 14 down first. What do you guys think?
I think we all agree. We have just questions regarding the placement. So, but we do agree that 12 or 14. But we will be very interested to see where do you actually land it distally. Munir believes that you may have to go down further down. We believe, I personally believe, and we'll ask the panel, that you could land it in the common femoral, the part of that we visualize on the angio.
So actually, if you land it first in the common femoral and you still have a lot of collaterals, you know there's a problem there.
I see.
So this is the problem. And
I
now
agree with that.
you will go to profunda better even if you have to.
So I think that's the next question starting on this side now. Tony, landing in the profunda or what, that little nub of the common femoral to start with? Or first do common femoral, and if you see collateral filling, then take it lower down and put a secondary stent, additional stent distally.
Well, I mean, you could do it that way. I think that you're going to learn a lot by this initial injection right here. So it looks like the common femoral is not completely normal, so I think you're going to have to take it down a little further.
Okay. Steve, quickly?
Yeah, I would definitely take it. I'd be very aggressive. I'd be very aggressive, well below the inguinal ligament.
Kenny, also below? You're thinking? Please.
Oh, sorry.
All I can tell you is that
I'd like to, I hate to throw this step in, give me the longest angled catheter that we have.
I'm not sure I'm happy where the wire is. Okay, I think I'd probably get the wire into the.
I'm not either. That's why I'm going to check that. The longest
And then I
catheter.
would probably send from the mid-femoral head on up. And I'll tell you, we've had a couple of cases where we stented across this, it just turned out to be torture long-term. I mean, absolute torture. Restenosis in this area, and there's no good treatment for it. So, I don't know, I'm a little bit leery, but I think I'd redirect the wire at the common femoral towards the, towards the deep vein.
So, I mean, I would agree actually with Kenny's comments. I'd be reluctant to stent further down unless you're absolutely necessary. You know, it's interesting because there was flow there. Now it's clearly not normal in that view. And yet it was open enough that he was able to get access and he had flow in it by ultrasound. So, and it's a relatively low resistance system. So if it stays open. And he's open more proximally, then in fact it may stay open without you having to stent across that common femoral segment. So I don't know. I think I would try and fix the upper
Give
part
me an
first,
8 long balloon, please. 8 long.
and then see how it goes. Yeah.
You know, I know you don't like to hear that. I think this is a really good case for her age, endarterectomy of the common femoral vein and stenting the rest of the vein. This is the best case because of her age.
Endarterectomy?
Yeah, endarterectomy of the common femoral vein, clean everything.
To be honest, I won't acknowledge publicly, this is new to me.
Oh, no, we do it. Actually, with those cases, clean it. It cleans better than the artery. And then do the stenting after that.
Endarterectomy?
I don't think there is a good solution for this because, as Kenny mentioned, I think putting a stent across that ligament into the femoral vein is going to be problematic. So I think it would be nice not to do that. I was just thinking, can you put a big DCB there, and this drug-coated balloon?
There is no wall.
And we use it for fistulas. So if we can use it for fistulas, I think it may be helpful to prevent restenosis in that area. I know it's clots, but it's probably some of it is also hyperplasia and inflammation.
Bruce, 8 minutes.
Sorry. All right. Well, my concern is she's young.
Yes.
She's young, and it's all about inflow. So everybody's making the same point. We need inflow to these iliac stents.
Correct.
And so part of it in my mind, that's why I went down and looked into the femoral vein. So now let me dilate through here. That wire's in the femoral vein. I like where it's at. Let's just dilate this. It's all about that inflow and whether or not you think you got enough, and that will predicate how low we got to make this stent, how low we got to put it in.
Isn't it that too medial to be the femoral vein? You think you are in the saphenous?
What's that?
Yeah, Bruce, I think you're in the saphenous vein, aren't you not? I mean, and maybe that's what you want to be your inflow, but I would look a little more towards the
Deep, yeah.
towards the lateral aspect to try to see if you got into the deep. I don't know. I'm not an expert in the veins as much as some of my colleagues here on the panel, and you.
This
Leave the
does
wire
look the
pulled.
saphenous, is that right? Huh? It is the saphenous. It is the saphenous.
It is the saphenous.
It's not the deep.
It
That's
is the
what-
saphenous. If I can get in the femoral vein, I got it.
It should just be called femoral vein. You should just call it femoral vein instead of the stupid superficial. It is called the femoral vein. So this is, but people, yeah. So
I think there's a recoil there,
Let me
so
just-
maybe repeat ballooning gently.
What's that?
I think there's a recoil there, so maybe it's low pressure, prolonged, gentle ballooning again. Anyone? We have last few minutes.
Let me get a little different picture here.
Okay. Peter, you would balloon again here, or because you just lost flow?
I think it's just going to keep recoiling on you.
Yeah.
I appreciate everyone else's comments, but I think that common femoral vein is going to be a nidus for
Tell you what,
restenosis and thrombosis, and I'd probably stay.
I can't make a stent decision yet, so I'm going to need to play. I'm going to need to get into something else in the thigh, and maybe I'll go into. Let me put the wire in between where the profunda and the saphenous is, and see if that makes a difference. So I'll need to.
But you would leave this wire right there, is that right?
Yeah.
Yeah.
So what I want is
So Bruce, you have 5 minutes left, so we'll just keep talking here, and whenever we are out, we will thank you for your tremendous live display of very, very complex cases.
Well, thanks for having us.
We can still continue. We have 5 minutes left, so keep continuing.
All right. Well,
So Kenny, I
Bruce,
think
why not stent from halfway up the femoral head, and that leaves your inflow. You have a lot of inflow, and you're not, it's less chance of fracture and so on. I don't know. That's probably what I would do.
But Bruce is going by your original recommendation, Kenny. He wants to get into the deep vein now.
Yeah,
he
but
wants to put a second wire and get into the deep
which
vein.
is fine. But I think in terms of where you end up putting the stent, you can balloon dilate that whole area. But you can see what happens when you balloon dilate it. You end up with a spasm and so on as you did. In terms of where you to stent, I think if you stent into any of those branches, profunda or femoral, then you're going to end up compromising your inflow. So I probably would stent from halfway up and the femoral head, and that's it. But that's just me. I don't know.
That's my mindset too, Kenny. I agree with you there. I'm just not comfortable making a decision yet as to where to put it, but I don't want it too low, and the thought of cleaning out this groin, we've done that, and it's like yellow grizzle that comes out of there, and our results haven't been very good with it, of cleaning out the chronic clot.
That is the saphenous.
And I like to use the lesser trochanter as a frame of reference, but got to be over there, right there someplace. Let's just get a catheter down a little lower, see if we can see something down there. Got to be, that's too lateral.
Promising.
This is why a lot of us like arteries. Anyway, Bruce, I'm just going to say congratulations. This is a great save, and it's a really hard case.
Well,
Bruce,
thank you. It's not, we'll see.
2 minutes left, Bruce, and work in peace, and we will keep following you for the remaining 2 minutes, and then say goodbye. But again, resonate everything that the panel has said. We are very, very grateful for you taking the time on a Friday evening to demonstrate such challenging and cases, and also talking through it so that our audience and panel can deliberate and learn from you. So thank you very, very much.
Let me thank Dr. Gandhi and Dr. Bloss, the team over there. Sorry I wasn't there, and our technicians, and Dr. Devane, thanks for having us. And sorry this wasn't very smooth, but maybe that's the lesson.
Actually, this is much better than having a slick crossing and a stent placement. We actually want to see in action, and this is exactly what we wanted.
You want to see me sweat?
We would, but you never do. You never sweat.
Yeah. And thanks to our professional IT team, they are outstanding. So
thank
you very much.
Thank you.
All right.
Keep working. Thank you all. Thank you, the panel, for the great discussion and all your feedback. I hope it has been an enjoyable session. And again, thank you for contributing to CVI 2018.